Welcome to our webinar series for professionals.
Hi everyone, welcome to the second webinar in a row with Helen Gauci, our dietitian in DNA Life. So I'll just do a bit of an introduction as what she is to talk about in a little while. But before then, of course, I'm Anne-Catherine, co-founder of Nordic Laboratories and DNA Life, where we focus on functional medicine, personalized medicine, and you should all have your VMS account or access, so you can go in and find more information about what Helen is going to educate around today, webinars, info on supplements and lab tests as well. So since last time, we have now got Prolon back in stock. So we have got the shelves are filled up with the fasting mimicking diet Prolon. If you need to get more details on that, you can find a webinar already on our YouTube account or in VMS under education, the menu under education. And that's of course pretty handy, at least for us on the Northern Hemisphere, because it's in time for the bikini season, so and swimming trunk season, I'd better say as well. And it's of course always time for longevity time. So and then the next webinar is on Thursday, where the topic will be mitochondrial medicine with a focus on CoQ10. I'm looking very much forward to that. I have my CoQ10 bottle standing right in front of me. So, but today is Helen's stage, and she will be talking about DNA risk. And it's a bit of a different test than the rest of the nutrigenetic test, DNA test that we have, because it's perhaps more of a disease-focused test with more of a shift towards, well, prevention is always something, but the purpose here is really to prevention of autoimmune conditions, or at least to better understand the terrain of your patients in relation to autoimmunity. So, and as always, the webinar will be recorded and we will share the slides as soon as we can, next week, probably at some stage. And make sure you ask questions in the chat. I'm sure I will not be able to answer many of them because I'm also a newbie to DNA risk, but put it in the chat and I will take it up at the end of Helen's presentation, and then we'll open up for some discussion then. So, and also write to each other if you feel like it. So anyway, Helen, enough from me. I'll let you take over the screen and share your slides.
Okay, so hi everyone. Thanks so much for having me again. Hi, I'm Catherine. Happy to see everyone here again. Can you see them? Are they up? Okay, so it is, as Anne-Catherine mentioned, it's quite a new category, actually launched June of last year, but we all know with the craziness of the last 2 years, things seem to kind of merge into each other, and I don't know if this test has been given as much attention as maybe we should have given it, as much as it deserves. So maybe just with the introduction that we had last year around the test, it will be really nice to actually go into the practicalities and the clinical utility of the test. We've had some of our practitioners working with the test quite a lot, and so we're slowly developing a bit of a case history around these tests. So I'm just going to put in my earphones quickly. I've got to, if you can hear me, if it makes any difference. I don't know if it's going to, but okay, so should be okay. Okay.
I don't think
there we go. Yeah, okay. Okay, so we'll just carry on. So what we are focusing on today is your HLA related autoimmunity. So it's in the DNA risk category, and just to go through this category and what we're really introducing here with this category, as Anne-Catherine mentioned, it is slightly different to the normal lifestyle genetics tests, in that instead of, I mean, it's still looking at prevention in many ways, but it is almost, as Anne-Catherine mentioned, more disease focused, specifically in the area of autoimmune disorders. So it's a category of gene tests that report on the risk of certain disorders that have a strong genetic component by analyzing genetic mutations or variations. And one of the tests within our DNA risk category, well, the first one that we actually have launched with last year already, is this HLA-related autoimmune disorder. Other tests in this category that will be coming, we will soon be seeing other ones around breast and colon cancer, genetic risk scores, and that's also falling more into this category of almost disease screening in a way, but again, considering that these are genetic variations and there are other environmental components that we always need to take into account. And so I wanted to share this image with you, which I find just really helpful when still being able to categorize where these groups of tests fall and why they are still very important to consider within the polygenic multifactorial nature of disease, rather than just focusing on something which is monogenic or oligogenic, just from this image. So with regards to the DNA risk category, HLA-related autoimmune disorders fall within this kind of this green space here, this polygenic space. So we've got different types of genetic contribution towards disease. Some with a very, very strong contribution from the genetic side, and that's when, say, one single gene mutation, and they're very rare in the population, will contribute towards a disease or a syndrome, and that's a very strong genetic contribution. When we're looking at this big yellow component here, these are where, again, there are certain rare genetic variations comprising of around 0.1 to 5% of the population who carry these variations, who develop these autoimmune or these specific diseases. And some of the autoimmune disorders actually have these rare variants attached to them. But most of our diseases of lifestyle, what we are really focused on in the functional medicine space, is the screen space, where it is many genetic variations together with diet, together with lifestyle, together with what you were exposed to in the womb, together with what your mother might have been exposed to or your grandmother might have been exposed to, with viral infections, whatever it may be, all culminating into that point in time that may express in possible disease, or actually what we're aiming to achieve is good health. And so we are still focusing on this, this polygenic area. But when we're looking at the variants here, they almost tend to have a slightly stronger association. It's more genotype phenotype association a lot of the time. The evidence is very strong around these genes, and just the clinical nature of these tests is slightly different to what we're looking at, instead of the understanding the biochemical pathways that govern health and disease. So it's slightly different to what we spoke about, say, in DNA health, where really understanding the biochemistry, that biochemical level contribution towards disease. We're now looking at specific areas related to a specific disease disorder, and in this case, starting off looking at your HLA-related autoimmune disorders. So very specific in what we are reporting on. So just really highlighting that. And so when we're looking again, and just to highlight here, even though these are polygenic in nature, there are various genetic and environmental factors that have been found to contribute towards autoimmune disorders. We all know this. And while an array of genes involved in both the innate and adaptive immune response, so considering actually what you might get from a DNA health test, from your vitamin D responsiveness, from what's happening in inflammation, especially in detoxification and oxidative stress. All of those things still need to be taken into account when considering overall contribution towards an abnormal immune response. What we're looking at here is the strongest contribution towards autoimmune disorders, and this comes from what we call the major histocompatibility complex, or MHC region of genes for short. So histocompatibility complex, start thinking immune-related function. So this complex of genes really controls your immune response to internal as well as external factors. So the gene products of this MHC region are termed your human leukocyte antigens, or HLAs for short. So it's a very big area of genes. So you've got your major histocompatibility complex, and the products of this complex are called your human leukocyte antigens, or HLA for short. And so this terminology might be familiar to some of you, maybe completely foreign to others. It's okay. We're going to go through some of the science around it. I'm not going to go heavily into the science. This is hopefully going to be a very practical session. There is a very science-based presentation that we do already have presented by Punita Patamba, and she was great and very instrumental in the development of this test. And has a strong understanding of the genetic component with her history in or her education in human genetics. So getting back to what we're talking about here, this MHC region and your human leukocyte antigens play a pivotal role in your antigen presentation of self and non-self, of what we recognize to be safe and what we recognize to be foreign. Okay, so these self and non-self peptides is where these HLA antigens play a very important role. They're like the guardians of your system, and they can recognize, is this okay? Can I let it in? Is everything going to function normally? Or I do not trust this peptide, and therefore, because of that, I'm going to have a very strong immune response to it. When it comes to the variations around these genes, the recognition of self and non-self sometimes becomes a bit blurred. So when you carry variations in these genes, sometimes your guardians don't always recognize what is safe and what is not safe. So sometimes something that should actually be considered as safe or minor in its pathogenicity will be regarded by your guardians as extremely dangerous, and you develop an extreme immune response to it. And other times, because of variations in these genes, your guardians don't really recognize that there's actually a really dangerous pathogen around, or a dangerous exogenous factor around. The peptide may actually cause a lot of damage, but your guardians don't recognize it as such. So they let it in and they let it come and do its thing. And because of that, it actually creates damage to your system. So it creates an autoimmune disorder because your body hasn't almost recognized it as dangerous. And the other time is when your body overreacts to something that it should actually consider safe. So that's just where understanding these HLA profiles and how they influence autoimmunity risk or protection by either binding pathogenic or self-peptides more or less efficiently results in the loss of tolerance, and therefore the risk of an autoimmune disorder actually being expressed. So just this image, and just explaining what this image is talking about here, and I just want to highlight it again, that we're looking at a polygenic understanding of autoimmune disorders, but also when we're considering breach of tolerance or autoimmunity, it's your HLA from your MHC complex and MHC region, which is really the biggest contribution from the genetic side. You've then got these genetic mutations from your rarer genotype groups, which we're not really going to go into. Those are your rare contributions towards risk of autoimmune diseases. We're then looking at your genome-wide association studies, where certain things are coming out around certain other variants in your inflammation pathways, in your oxidative stress and detoxification pathways, all playing a role in autoimmunity, and some autoimmune disorders having very specific peaks within these studies, showing very isolated clusters depending on the autoimmune disease, but that research still seems to be, in its sort of quite in its infancy, some of it. And then we've got our epigenetic changes. What happened was, as I was saying, with what happened in utero, what happened with your grandparents, all affecting, we know this transgenerational health being very important in your ability to recognize self from non-self, to manage your immune response. So that also playing a very important role, and also obviously what we've been exposed to over our lifetime. And you'll see some of these, just these descriptions here around acetylation, methylation, ubiquination. These are some of the pathways you might start recognizing, or the biochemical reactions that you might recognize that occur actually, and we talk about in DNA health. So that's where really what might be very nice to do often with these autoimmune disorders is considering your DNA health test together with your HLA test going forward. And that's where I will speak about, in the case that I'm going to present, speak about that. So just really emphasizing, you've got a lot of different contributors towards the risk of eventually developing an autoimmune disorder. And obviously you need the environmental trigger. You can have all of these genetic variations, and without the environmental trigger, you may never see anything actually occur. So environment is very, very important in the risk for autoimmune disorders. And just understanding that, or actually highlighting or emphasizing that fact, is we're seeing the prevalence, or more the incidence of autoimmune disorders actually growing within recent years, within the last few decades. And this is because we haven't changed our genes that quickly, because that takes a very long time to do, but what are we being exposed to in our modern Western lifestyles? What deficiencies are we carrying in terms of nutrients, and what toxins do we just have at high levels in our system that is increasing the risk for autoimmune diseases? So now getting into just a little bit of the nitty-gritty sciencey part, and hopefully I will do this part justice. And what we're talking about here is the genetic organization of your HLA gene complex, so your human leukocyte antigen gene. And it's not to really have to focus on all of this in a lot of detail, but just to highlight the extreme complexity of this gene and what we're able to bring to you, and I'll start getting to that in the actual report. But in our major histocompatibility complex, it's an extremely gene-rich region, with one of the main products being your HLA complex, and in your HLA genes, there is a lot of variation that occurs from population to population, from individual to individual. There are many, many, many thousands of variations and points on this gene that we can analyze to actually give results on the amount of variation that you have on this gene. So it's a highly what we call polymorphic gene region. There's a lot of variation that occurs from individual to individual. So when we do the analysis in the laboratory, what actually is happening is we are analyzing thousands of variations, thousands and thousands of variations, that then goes into a very complicated algorithm using bioinformatics to spit out your HLA typing. Okay, and then when we're looking at your HLA typing, we class it according to the different regions on your HLA gene, your region, your sort of your class 1, your class 2, and some typing, not that we're reporting on it, goes into class 3, and there is a little bit on class 4 as well. So just to highlight, you've got these in your region, you've got HLA class 1, HLA class 2, and HLA class 3. And what we are reporting on in our test, and I'll just actually show you here, we're reporting on class 1 and class 2. So going back to just the nomenclature, and this is just, I think, helpful for you to understand when looking at these genes, because it's very different to what you would expect to find in a DNA health test or any of our other genetic tests. Just how we're naming the genes is very different. What happened to C's and G's and T's and A's? What happened to our little 4 letters and being able to interpret it so easily? Well, because of the amount of genetic variation that we're analyzing and this algorithm that we are looking at, the way that HLA is reported is according to, they call it a haplotype or a typing system. So they look at all of the different variations, and then they give you kind of a grouped name. They classify you into a group based on the thousands of variations. So they say, well, because of all these variations, we'll still classify you into group A, for example, or group B or group C. So that's just, they're trying to simplify how the interpretation of this very complex gene region works. And that's the smart geneticists and bioinformatic individuals and engineers that work on that. But what we want to really focus on here is just giving some understanding to this. So when you look at a report that has HLA involved in it, you will see the gene name being written. So you will get this HLA gene being written, and that stands for your human leukocyte antigen. What does that mean? It's the region and the prefix for the HLA gene. So it just really means, what is the gene's name? A human leukocyte antigen. Then you'll see this next bit. So you'll see in the report, you'll see this, what is this? DPA1, DPB1, we don't really know. Well, let's find out. It's the particular locus, so it's the position on the gene that we're talking about. So when we're looking at these DRB1s or DPB1s, we know that they are in the class 2 region of the gene, and that's, you'll see it in the report as we go through it, but it's the position on the gene that we're talking about there, the locus on the gene. Then you will see it's sometimes written as a star and a number, or it's just written without the star. So it just depends on how it's written in the literature or how different reports will present it. But it's sometimes written with a star, sometimes without, but it gives you now your HLA, then your dash, and then this DRB1 or DPB1 or whatever it might be, and then a number. And so that number is the group of alleles, that group of genotypes, if you want to call it that, that encode the specific antigen on the HLA gene. And then after that, we're looking at, it gives you a colon, and it gives you another set of numbers. And that's this very specific HLA allele that we're looking at. So it just becomes more and more specific. So we've got our HLA gene, then we dive a little bit deeper, and then we get to where on the gene are we looking. So it's the kind of the position, the first position, the locus. Then we want to see, okay, well, what group of alleles does this specific person have? And that group of alleles for that person is a 13. And then we get very, very specific. So we just get our magnifying glass in, and we go even deeper into the analysis and the interpretation, and we see the colon and then the next two numbers being written. And so that's giving you your very specific HLA allele. So when you then look at it in a genotype report, this is what you will see. So we are reporting on class 1 and class 2 regions on the HLA gene. These are the two regions that are strongly related to autoimmune disorders. The class 3 region is more strongly analyzed when you're looking at matching for donors for certain cancers. That's the kind of thing that you start looking at in the class 3 region. But for autoimmune disorders, you're looking at class 1 and class 2. And so in class 1, you'll get your class 1, your A, your B, or your C. So that would be the locus on that in class 1. And in class 2, you'd get your locuses DPA1, DPB1, DQA1, DQB1, and DRB1. Then you will get your specific group of alleles. So that first set of numbers, and then we just get very specific with the specific allele on that locus that we are interested in. So it becomes very specific. Why do we have 2 columns over here in class 1 and 2 columns over here in class 2? So remember 2 chromosomes, so a pair of chromosomes that we are interested in when we're looking at, so what we got from mom and what we got from dad. And so that's why it's listed like this. So we've got what we got from mom and what we got from dad. Okay, so if we were to take this first one as an example, HLA class 2 DPA1, we see that this individual is 0103 genotype result. And on what we got from dad as well, say for example, we would say 0103. So this person is homozygous for DPA1, and the genotype result is 0103, 0103. Okay, so that's just showing you whether they are heterozygous, remember 2 different, or homozygous, 2 of the same. And so just to emphasize that again, DRB1, it's the HLA locus. Then the first set of numbers, it's the group of alleles encoding the antigen or homology to other alleles. And then the second group of numbers, that's your specific HLA allele, okay, specific kind of genotype that we're looking at. And so you don't really need to know what these mean too much, because we try to interpret it for you, and we've tried to report on it in such a way that when we're talking about a specific autoimmune disorder, we have mentioned which risk genotypes are related to that autoimmune disorder. So it's all there for you in the report. And then what we do also in the report is for specific autoimmune disorders, referring to specifically your 2 nephropathies around autoimmune nephropathies, your idiopathic membranous nephropathy, as well as your IgA nephropathy. There are now single nucleotide polymorphisms, so specific genetic variations related to these types of autoimmune disorders that we really need to highlight if you are trying to get more information on these nephropathies, because they are very strongly related in this HLA gene region, and we would want to report on them as the single nucleotide polymorphism. So some areas you can report on as single gene variants, other areas you report on as these groups of HLA typing. Okay, so it's just giving you that further information specifically for these nephropathies. If you suspect an individual has a risk for one of these nephropathies, it's very important to understand what they are getting from their genes. Okay. In terms of the impact here, what you will see is if it comes out with a plus, it means that genotype risk variant is that risk variant is present, so that the risk genotype is present for these bottom 2 in this individual. And then you can see when it's the pluses for the next one, that means that those risk genotypes are present, or the variant is present, increasing risk for these disorders. So that's just really highlighting what we see in the report. And so when we're looking at what you're actually going to get, what information are you going to get from the report? Well, we speak about some of the most commonly reported autoimmune disorders, with the literature that was strong to report on these autoimmune disorders around HLA typing. So obviously, there are many other autoimmune disorders, and the list is constantly, we're constantly growing the list based on what we're seeing from the literature. But these are the ones that we were able to very confidently report on based on the associations that we could see with the HLA typing that was really, really strong. And carrying those risk genotypes significantly increased one's risk of developing one of these associated disorders. So you will see that the autoimmune diseases discussed in the report are listed according to alphabetical order. So if you're interested in Alopecia Areata, A start at the top, and Vitiligo will be at the end of the report. And what the report provides is insights into environmental contributors and highlights the HLA alleles, both the risk and the protective alleles in the MHC related, as well as possible MHC related gene variants associated with the disorders. And this is based on the available literature. So it's very strong in the science backing that we have when we're reporting on these risk genotypes. Something else to note is when we list the risk genotypes in the report, they are listed according to the strength associated with the disorder. So if we have HLA X genotype as being the strongest one related to Alopecia Areata, it's going to be listed first. If HLA Y genotype was sort of related, but not as strongly, so the significance or the odds of developing alopecia wasn't as high as with the X, then it would be listed afterwards. So the strength of the genotypes are listed in descending order, so strongest at the top going down, and we also do mention whenever there are protective genotypes as well, and that's also very important to consider sometimes, especially when thinking about the direction of kind of understanding what possible autoimmune disorder an individual has. If they've got a lot of protective genotypes on a specific for a specific disorder, then you might want to look a little bit further or do further investigative tests because of the strong protective effect from their genotype. So if we get into the report, and what we would see in the report is pretty much these 3 pages starting up. So you'd open up your report, it would say, hello, so-and-so, welcome to your DNA risk HLA autoimmune related report, genotype report. And this first page 3, you would get your genotype results class 1 and class 2. You would then just underneath that see these genetic variants related to that specific those specific disorders. So these are your patient's results or your results if you did it for yourself. And then we just want to highlight what we are expecting to see in the report, and we are going to be speaking about these autoimmune disorders in the body of the report. And then if we go through the report and we see we'd like to understand a little bit more about celiac disease, and does this individual carry risk variants for celiac disease? Well, then we'd page through the report until we get to celiac disease. And we want to remember to keep this individual's genotype results in mind. So that page 3 where we saw those genotype results for that individual, we would then want to cross-reference with what we're seeing that with the genotype risk alleles associated with celiac disease. So in the page for celiac disease, you're going to see these risk alleles being presented. So the exclamation, these are the risk alleles associated with celiac disease. This is not the patient's genotype results. These are the results, or these are the genotypes associated with celiac disease. You then cross-reference with what is going on with this individual's genotype results. The reason we don't present it like we do in our other reports with giving a high impact or anything like that is because, as I mentioned, there are thousands and thousands and thousands of variations that you need to consider when eventually getting this HLA typing, and the software for any software is just not able to really give that to in a report format. So what we're able to then do is we then need to cross-reference. So we start looking at what we're seeing in the risk genotypes, and does this patient carry any of those risk genotypes. So we see in DQA1 star 0505 with DQB1 star 0202, that's going to be the strongest risk combination for celiac disease. And does this individual carry those specific variants? No, they do not. What they do carry is a combination of DQA1 star 02 with a combination of so DQA1 star 02 with DQB1 02. Okay, so if you look through the genotype results, you will say DQA1, they carry an 02 genotype, and DQB1, they carry an 02 genotype. So there is a risk, but if you look at where it sits on the scale of being high to low, it's not very high. So would you consider this individual as having a strong risk for celiac disease? Obviously, depends on what else they are presenting with, but it is not a strong risk. You would then look at what else is being said about celiac disease in the report, and that is this further information that we provide for you. So what we say celiac disease is triggered by, it's genetically susceptible individuals, but we need the gluten there. So is this person taking in gluten? Are they experiencing some kinds of symptoms towards the gluten? And do they have other contributing factors that might increase their risk of celiac disease? Is there a close family relative that has celiac disease or type 1 diabetes or another autoimmune disorder? And what other infections have they been exposed to over their life that might further contribute towards celiac disease? What is their gut health like? What are their symptoms like? And that's where you do start looking at other investigative tests to really get a further understanding of what is going on with the autoimmune disorder and relating it back to the genotype results and the person sitting in front of you. And this is where what we have available to you, what we cannot put into the report because it's extremely detailed, but we have done a very thorough review of the literature for each of these autoimmune disorders, and we then provide you with a lovely white paper that you can then go, and this is accessible to all of you. You can go and see, well, I'm very interested in celiac disease with this patient. I can then start reading about further information around celiac disease, and does that provide further clues as to either contributing towards the risk or actually ruling out the risk, and we can move on to the next autoimmune disorder, or in fact something completely different that is actually causing the symptom set in this patient. And just another example here, again, you would see for Iga Nephropathy as an example. I'm just using this one because we would want to keep in mind these specific genotype results that are listed on that front page. And then you would cross-reference back to the risk alleles and see, okay, this person is carrying, is homozygous for this genotype over here, and we're seeing it in the risk alleles associated with nephropathy. So is that a risk? Well, do some further investigation of the client, look at kidney function, look at other environmental factors that contribute towards nephropathies, and you can go from there. Something else just to keep in mind, and something very interesting always when we're looking at a lot of the autoimmune disorders, is they can actually a lot of the time be counteracted. In the literature, it shows that if you carry a risk variant but you carry the protective variant as well, it cancels it out a lot of the time. It cancels out the risk. And so in this individual, yes, they're carrying the risk, but they are also carrying a protective allele. So it's always important to go through the report and looking at what are you carrying risk-wise, but what are you carrying protective-wise as well. And do those protective genotypes cancel out the risk genotypes? And if they do, we do mention that in the report. And I think that's really useful, especially if you have clients presenting with a really quite generalized symptom set, from painful joints or painful muscles, difficulty with mobility, headaches, fatigue. That could be fibromyalgia, it could be SLE, it could be it could be rheumatoid arthritis, it could be multiple sclerosis. All of those autoimmune disorders present with those same or very similar symptoms. And that's the tricky thing around autoimmune disorders, is that the blood tests aren't always that specific, and they aren't always indicated if you don't have further clues around where to go, which direction to go to for those blood tests. So they're not always firstly indicated. So this report provides you with those further clues. Which specific blood tests would we want to do? What is the symptom set? What are the environmental factors specifically relating to that autoimmune disorder? And that's what we've collated for you in the white paper, in the genotype results, and the body of the report. We actually give you a synopsis of that in the report. So it gives you a lot of clues as to where you should go to in terms of follow-up tests, and giving clues around the diagnosis for the client, as well as then what we can do around mitigating or decreasing the symptoms of that autoimmune disorder and improving their prognosis. So that is what is given in the report. So with that, I've got a case study that I'd like to go through. It was actually a case I did with a practitioner who did the battery of lifestyle genomics, the nutritional genomics tests with this lady. There was quite a strong emphasis on inflammation from this individual, with a poor oxidative stress and detoxification profile. So already from DNA health, we start to get the clue, well, whatever this individual has been exposed to from an oxidative stress point of view, they do not manage oxidative stress, or they don't manage oxidative stress as well. They don't detox very well, so further contributes towards oxidative stress burden that increases inflammation. So all putting quite a strong load on overall immune function. A lot of the time, what we have actually figured out or picked up as a pattern with autoimmune disorders is there's a strong actually a strong amount of evidence coming through around pollution increasing risk for autoimmune disorders. And it's because of the high oxidative stress burden that goes onto individuals, and the oxidative stresses, or these the pollutants that an individual is exposed to, presents as different peptides eventually, and our body recognizes these peptides as extremely dangerous if you are susceptible already, and completely overreact. So there's a complete overreaction of the immune system a lot of the time to these oxidative stresses. And so she already, having presented with a poor detoxification and oxidative stress profile, we then see, well, then we then obviously we had the case history, and this lady presenting, she's sort of late 30s, generalized pain, mainly in the joints, fatigue that comes and goes. She's got gut health concerns. She feels like it might be related to something she's eating, but really just not happy with just general gut health. She's experienced recent skin discoloration and pigmentation concerns, she says, just on her arms, and she doesn't know if it's because of some topical treatments that she's taking, she started using, or it was recently our summer holidays, and she was out in the sun a lot, so she doesn't know if it was that. She then did some bloods that she brought along to this practitioner, and she did present with iron deficiency anemia. She had a low vitamin D status. Her high sensitivity CRP, or ultra sensitivity CRP, was also high, and she also presented with dyslipidemia. She had previously been to a few other practitioners, and with those results, actually presented with a blood test showing raised anticyclic citrullinated peptide antibodies. So for those of you who are kind of new to this field, these anti-CCP antibodies are markers of an autoimmune disease. And often, so it's very strongly related in the diagnosis with rheumatoid arthritis, but it's actually being used more commonly now and quite generally to just pick up if there's an autoimmune reaction. And what the literature is suggesting is that many autoimmune disorders actually show these anti-CCPs coming up, and they can actually present 10 years prior to one experiencing symptoms. So a very interesting antibody test to consider with regards to autoimmune function. She has a normal BMI, and her waist hip ratio, so she's kind of what we would call skinny fat. Normal BMI, but at waist hip ratio was quite high, and a slightly high fat percentage. She's following the typical modern Western diet, not great in polyphenol and phytonutrient and vitamin-rich foods, high in refined carbohydrates and saturated and trans fats. She is on an estrogen contraceptive. She's an ex-smoker, and she has reported previous viral infections. And when she went to a previous practitioner, there was suspected fibromyalgia or another autoimmune disorder. They couldn't quite pinpoint it. She couldn't quite pinpoint it either, or there wasn't really a strong diagnosis given. Suspected rheumatoid arthritis or SLE, or just and with recurring headaches and all of this. So this is what she kind of presented with, and she wanted to get some clarity for herself. The practitioner wanted to get some direction as to what he should do. Obviously, understanding the biochemistry and looking at the bloods, there was a lot he could already do. The modern Western diet, he could already start fixing up a lot. But we recommended then doing the HLA test because it was going to provide further clarity as to what, if there was an autoimmune disorder, what could it possibly be? And then what could we do about it if there are specific recommendations to that autoimmune disorder? So that's where the real clinical utility comes in with HLA. And here we see the individual's genotype results, and that's reported on page 3, as I mentioned, of the report. And then we start going through the report. Step-by-step process, we look at what are the individual's genotype results, and we start looking at each autoimmune disorder and just cross-referencing. So I'm not going to spend a lot of time where there wasn't a lot going on, but I'll just highlight for you as we go along. So when we look at Alopecia Areata, it's the first autoimmune disorder that we are reporting on. It's an autoimmune disorder that results in hair loss. And so what we're seeing is your HLA class 2 risk as well as protective genotypes. And we relate it, or we cross-reference it back to the individual's genotypes, but nothing came up. So nothing there, even though she did actually report some hair loss, but nothing that came up. Next one was Ankylysing Spondylitis. It's one of the rheumatic diseases, and presents with inflammatory spinal pain, gradual immobility. She has a lot of pain. She has some gut issues also related to that. Let's see if she has any of the ankylosing spondylitis gene risk variants. And if we look at the HLA risk genotypes, the B27s are very strongly related to ankylosing spondylitis in class 1. She doesn't carry any of those, so we can move on. In celiac disease, she did present with the DQA1 and DQB1 combination that we can see over there. There is a risk, and we would want to then consider it, especially remembering she's presenting with gut health issues. She's got a low iron, so iron deficiency anemia, gut health issues, that is something that is related to celiac disease. And so we would want to, in fact, do further testing around celiac disease in terms of the specific IgA and IgG antibodies. She is taking in enough gluten that those would come out positive if she did present with celiac disease. So that would be something that we would want to consider, especially her presentation of poor gut health symptoms. So that's already a clue based on her history that we would want to further investigate this, and she does carry some degree of risk. Often, interestingly enough, celiac disease genotype risk variants are often related to other autoimmune diseases as well. So we would want to do further investigation of if there were any other strong relations with any of the other genotype, any other autoimmune diseases that we are reporting on. So then we looked at some of the thyroid-related autoimmune disorders from Graves' disease, and we're just actually seeing a little bit, but now looking at where they are listed in the results table for the risk variants associated with Graves' disease. Remember, when they are listed high up in the table, that's when they are strongly related. The lower they go down, the less significant that association is with Graves' disease. It has been associated, but the risk is lower. So we would want to see, well, yes, there is a little bit, but she's actually, her thyroid function was normal and nothing else was really presenting there. So, and on top of that, she actually is carrying the HLA-DRB107 protective genotype, which may actually counteract a lot of the risk variant that she is carrying, or that risk variant that she is carrying. So yes, she's carrying a risk, but she's also carrying a protective allele. And so, and she's carrying another protective allele. So she's actually got more protective genotypes compared to what she does in terms of risk genotype. So you can see protective versus risk. It's much more on the protective side. So we would probably rule out the Graves as a strong association. In terms of Hashimoto's thyroiditis, another one of the thyroid diseases, autoimmune diseases, there was no cross-reference. So there was actually no associations there in terms of genotype risk. In terms of IgA nephropathy, there was a little bit that came up, and now we're looking at the strong one here. So this is the strongest one listed, and she does carry the variant. She in fact carries homozygous variant here, so it's very strongly related to this genotype. But she is also carrying some of the protective genotypes. And so we would want to then consider what has she been exposed to, and also what is the other information around the IgA nephropathy. So if we were to go into further detail around IgA nephropathy, we do know that it is actually very strongly associated with the Asian population, and so this lady is not Asian, and so we would want to see what other triggers she's been exposed to, and possibly if there are any kidney function issues, because she's carrying a little bit of both, but she is actually in fact carrying more of the protective genotype. So we would probably move on, and those are not, it's not really coming through in her symptom set. For idiopathic membranous nephropathy, she's carrying again a risk variant. And then she is not, sorry, these, I should have removed these, but she's not carrying any of the protective alleles for IgA nephropathy. So that's just something we would want to, then we would say, okay, well, she's carrying the risk, but she's not really carrying any of the protective. And so there might be something that we might want to look into in terms of the nephropathies. And as I mentioned, both nephropathies, both the idiopathic as well as the IgA nephropathies, are mostly prevalent in the Asian population. That's what you will find from our white paper. And you can look into what other triggers increased risk of these nephropathies. A lot of the time it's bacterial infections, chronic infections, chronic urinary tract infections that increase risk of these nephropathies. So that would be a very interesting question to ask if these risk variants did come up with these individuals. When moving on into the report, we would look at Lyme next, and that's what's reported next. And we didn't see any risk variants that she carried that is related to Lyme disease. So then we would go on to the next one. For multiple sclerosis, we did actually see this very high risk one carrying the DRB 11501. And for her, that is something that we would really want to consider because of her symptom set. They are all they're the triggers that are there. It's the smoking, the low vitamin D, the poor gut health, as well as then the viral infections. And she's carrying the highest risk genotype for multiple sclerosis. So that is a very strong indicator that there might be something to do with multiple sclerosis. The combined effects, and this is something also important to keep in mind, and this is what you would get from the white paper, that the combined effects of HLA DRB 15001 positivity, together with your Epstein-Barr virus infection results in up to 6-fold increased risk of multiple sclerosis. So there's a very strong risk for MS for this individual. And so we would want to further look at, we would want to further investigate what is going on in terms of her blood. So around vitamin D deficiency, other areas of inflammation, what is her folate and B12 looking at like, what are her homocysteine levels looking like, because that all affects myelin sheath degeneration. So all very important factors to consider, and that is a very strong one related for her. So we would want to say, okay, this is a big red flag. And so something we would really want to look into in more detail is the multiple sclerosis. The next one that was strongly indicated in terms of previous practitioners suggesting this was rheumatoid arthritis. And so this is something where I think the report can be so useful. It is, again, giving insight as to whether to go down that avenue with further testing or whether we go down a different route because of the clues that we've received from this genotype report. And so what you would see from rheumatoid arthritis here is actually so she is carrying a risk variant, and she's carrying this, what we call these novel risk alleles, and I'll explain those to you now. But she's also carrying a protective genotype over there. So just highlighting this, when we're talking about rheumatoid arthritis, 95% of individuals who suffer from rheumatoid arthritis will carry what we call these high risk shared epitope alleles. It's the alleles that we always see in individuals with rheumatoid arthritis. It's reported in all the studies that they always come up. If you're carrying one of these risk genotypes, these are the strongest ones associated with rheumatoid arthritis. And so those would probably be the strongest indicator for something for her, indicating rheumatoid arthritis is the actual autoimmune disorder that she is suffering from. She is a carrier of one of the more recently identified risk alleles, this DPB10401, but she also carries a protective genotype also on this DPB1. And so because of that, we might almost suggest that there's a bit of a cancelling out of these two genotype factors. And so if we look further in the report, we might get some further clues as to something else being more indicative of the autoimmune disorder. So for her, when we looked at SLE, when we started doing the cross-reference of risk genotypes and protective genotypes, we started down the list. So looking at HLA class 1, the A29, she didn't have, the B51, she didn't have. Then we start on the class 2 side and we start looking at what she might be carrying over there. And she is in fact carrying DQA1, star 0102. She's carrying the DRB1 genotype, that 1501. She's carrying DRB107. She's carrying the DQB1 star 02. She's also carrying the DQB106. And she is not carrying any protective genotype results. So When we're looking at SLE and the number of risk variants that she is carrying, it's very strongly related to SLE. Her symptom set also strongly suggests possible risk of SLE. In terms of environmental factors that have been suggested to be associated with the development of SLE, it's the genetically susceptible plus exposure to silica, smoking, vitamin D deficiency, and Epstein-Barr virus infection. She has had previous viral infections. She couldn't mention what they were, but we did see the viral infections there. She's an ex-smoker, so there is that higher oxidative stress burden. She has that poor oxidative stress and detoxification and an inflammatory profile coming from DNA health, and she has a vitamin D deficiency. Her symptom set is painful joints, headaches, fatigue, which is also all associated with SLE. What's also very interesting around SLE is that it can take up to 6 to 10 years for the correct diagnosis of this disorder. So very important, by understanding if an individual has the genotype results that are associated with this disorder, to do further investigative tests into the specifics around this, possibly looking at then also just distinguishing between the two, where she had the highest risks coming out, and this was for SLE, and then the other one was for MS, for the multiple sclerosis, which shared very similar symptom sets, but based on the symptom set plus the genotype results, it's very, very strong for SLE. She also mentioned that skin discoloration coming through. In terms of improving outcomes, and this has all been very well studied and strongly suggested as good evidence for improving outcomes, attaining and maintaining optimal vitamin D levels, degreasing may decrease disease activity and improve fatigue, converting to an anti-inflammatory Mediterranean-style diet, which she is not doing, but we really need to focus on. She needs to have a strong focus on her vitamins A, B, C, D, and E, as well as the minerals calcium, zinc, selenium, iron, and copper, with sufficient polyphenols in the diet. And that's going to mediate overall inflammation and improve outcomes significantly for this disorder. The last one that we just want to look at in the report, and we wouldn't want to leave it out, is just considering the last disorder that we report on is vitiligo. And here we are, it's this discoloration, this white patches on the skin, often associated with other diseases, autoimmune disorders, from rheumatoid arthritis to psoriasis, as well as your SLE. And when we look at risk variants here, she is in fact carrying a risk variant for vitiligo. She did also mention discoloration or different pigmentation on her skin. And so when we look at then the contributing environmental factors around this, it can be for vitiligo, skin trauma, but also chemical-induced depigmentation of the skin and skincare products. So she did change her skincare products recently. It's very important for her to consider what is in those skincare products. And then also, interestingly enough, for improving outcomes, now we're wanting to recommend a polyphenol-rich diet, but we also might want to strongly consider certain foods that might actually exacerbate or aggravate vitiligo, and they are listed here. So just interestingly that some of these actually may exacerbate the issue around vitiligo. Obviously, we would want to look at that in a little bit more detail. So attaining and maintaining optimal vitamin D levels also shown to improve pigmentation. A strong thread throughout here is looking at the vitamin D, and I'll mention a study that actually looked at vitamin D and omega-3 fatty acids around autoimmune health. And so for this case example, the two strongest ones where we saw very strong relationships between genotype and autoimmune disorder because of the shared risk variance was around SLE, number 1, and multiple sclerosis. In terms of diagnosis for SLE, we would want to look at a very specific antibody test. This is anti-nuclear antibody test. So now it's indicative of doing that antibody test and seeing if that comes out positive. Also looking at, which we already did, was the CRP, but your erythrocyte sedimentation rates, your ESR, if that comes out positive, other complement protein levels, looking specifically at liver and kidney function tests, creatinine kinase, it's a marker of muscle damage or oxidative stress. So that might be very useful. And then also looking at your protein to creatinine ratio. So all looking, again, also at kidney function. And then if these come out positive, it's a very strong indication that it is in fact SLE. And then we can look at, obviously, the diet, the environment, the nutraceuticals that we would want to put into place, as well as any other immunotherapies to help with this autoimmune disorder. So now we've got a very clear indication of the route forward, as well as how to improve prognosis with these complementary therapies. If these areas, a lot of these things do come out negative, we could also consider doing some further MRI testing to consider if it is in fact multiple sclerosis. In this individual, these follow-up tests were done, and in fact, it was very strongly indicated that it was SLE that this lady did suffer from. And so that's just giving some information on when this test would be most useful, trying to go through how to read the report. I know I'm the first to admit it can be quite cumbersome, and you just need to go through it on a step-by-step process. The reason it is reported in such a way is that just again highlighting the complexity of this HLA gene region, but also hopefully highlighting the importance and the clinical utility of this test, together with our other tests, understanding that it can provide real direction for individuals when you are struggling with gaining a diagnosis, but just getting some clarity for the direction for your therapy, for your interventions. And so for individuals who are struggling from or reporting chronic fatigue, fibromyalgia, generalized pain, whether it's in the joints or with movement, if it's muscle pain, nerve pain, sometimes it's difficult for patients to distinguish. If the gastrointestinal symptoms, they're often related obviously to celiac disease, but gastrointestinal symptoms may aggravate or actually set in motion a lot of autoimmune disorders. So there's a lot coming out on that, as I'm sure all of you are well aware. If there's periodontal disease, it's very strongly related to rheumatoid arthritis. There's a very strong association there. So if you are picking up periodontal disease in an individual and they are suffering from any of these symptoms that I've just mentioned, you might want to look at further investigation with this test. And then also any abnormal blood results from your thyroids to your antibody testing, your anti-CCPs, even if there's an abnormal ferritin or a high or a CRP that's abnormally high, those are all indicative of an autoimmune response that you would want to get under control. And understanding where these risk genotypes are for an individual, you can target their therapies by understanding if there is a specific autoimmune disorder actually presenting. Scarily, with a lot of these autoimmune disorders, they go undiagnosed for years and years, and the evidence around that for late onset actually for autoimmune disorders is becoming much higher. So the prevalence of that is becoming higher, and the diagnosis also takes a really long time. So for both those reasons, when we're looking at HLA, it's very useful to consider this test. Also, if there's any family history, and of course, known environmental triggers together with symptoms. Think of viral infections, smoking status, high BMI, low vitamin D, high oxidative stress exposure. Those are the biggest things that can trigger an autoimmune disorder in terms of environmental factors. From the from the clinical perspective or the clinical utility side, just to highlight, it helps with screening at-risk individuals. It helps with increasing the early identification. As I mentioned, that anti-CCP can actually be picked up as a marker 10 years before an individual actually presents with symptoms of an autoimmune disorder. So also then looking at if there are risk factors from the environment, together with certain symptom sets or family history, you would help by doing this test for early identification of an autoimmune disorder, and to really stop or decrease the progression of the disease. Improving prevention by removing any risk factors such as smoking, such as overweight, improving vitamin D status. It offers these diagnostic insights, as I showed you with this case study, and it helps to guide therapy decisions, because each autoimmune disorder has similar therapies, but there are some very specific ones, as you could see with regards to vitiligo versus MS versus then your SLE. And so just to highlight some nice resources, I mentioned quite a few times throughout the presentation this autoimmune white paper that we have compiled for you. So it's a really good presentation of what the literature is saying right here and now. Then there's the scientific webinar presented by Punita. So that's if you want to understand the science around HLA in further detail, and that is actually recorded and published on our DNA Life Academy site. And then of course your DNA Life support team. So if you have these complicated cases, or you would like to do this HLA test and you would like help with the interpretation, we are more than happy to help go through this test with you in more detail. It does take some practice, but the clinical utility that we've seen in practice has been really great, from either identifying the possible avenues that you would want to investigate further, or in fact saying, well, there's nothing coming up in the report, and it might be just something else altogether that we would want to investigate from the chronic inflammatory point of view. Lastly, just something that I didn't include here because of time, and I see I have gone over, but just a paper highlighting the importance of diet and lifestyle with regards to autoimmune disorders, and the emphasis that autoimmune disorders are occurring later and later on in life, is that there was actually a 5-year randomized control study done with supplementation for 5 years of vitamin D, as well as quite a good dose of omega-3 fatty acids. And by taking that, the vitamin D, and then combination with omega-3 fatty acids, there was a significant decrease in the incidence of autoimmune disorders in the trial, in the intervention group. So just highlighting the importance that if you, and the effect was stronger in individuals with a family history of autoimmune disorders, which indicates if you have these risk genotypes, that's a family history, just really showing you right there. And what you can do from the prevention side is, for those individuals, it's not just a nice to know, but an actual essential to look at those two supplements, the vitamin D and the omega-3. So just really helpful information that you can get from understanding your genotype results and looking at HLA in more detail. So that's me for this HLA webinar, and hopefully you will be able to use it and get the value from this test.
Excellent, Helen. Thank you very much. I'm sure this was a lot of new information to quite some of us, at least, at least to me. It's a very interesting way of looking into prevention and understand things a lot more. And like, so with the DNA health, we have the ApoE genes, and that tells us some risk in regards to dementia, and of course this adds like a whole new dimension in order to understand autoimmune conditions as well. There wasn't many who had any questions because so I'm not gonna start reading up all sorts of questions to you. But I just wanted to say that something I have been looking into also throughout the years is like panels that looks at autoantibodies in regards to autoimmunity, and because I thought it would be smart to do a screening to see, well, what autoantibodies are already available, but unfortunately the labs who ordered these larger panels weren't very reproducible, so I just had to stop looking into it. But here it gives a clue as to what can we refer back to the own GP to look at a bit further in a more serious way, rather than like get the doctor to look and they won't really look anywhere. But here, if you have some evidence as to what goes on at a genetic level, the request of asking for autoantibodies at the GP seemed quite strong at least. So in that way, I think it's a very neat test to have, to understand any future risks of autoimmunity later on in life and how to prevent it. So Helen just showed the DNA Life Academy website on her slides. It's academy.dna. No, sorry, it's it's DNALife.academy.
DNALife.academy.
Yeah. And for those of you who haven't signed up as users there, please do that, because there is a lot of information in regards to all our genetic tests in there. And of course, this recording will be shared. So when you do your first risk test, you might want to cover Helen's presentation again, and we will share the white paper as well with all of you, and the slides. So thank you very much, Helen, for your very detailed explanation about the test. That was well needed. I hope to see you soon sometime. We don't have anything planned, but I'm sure something will pop up at some stage throughout this year. And thank you everyone for joining us, and enjoy your evening or rest of the day wherever you are in the world. Thank you, and thank you, Helen.
Thank you. Thanks so much, Anne-Catherine. Bye, everyone.
If you do not already have an account with us, please contact our team and we will assist you. If you found this webinar helpful, please like and subscribe to our channel.